Good morning, everyone. Today we will discuss the cerebellum, its anatomy, major afferent and efferent tracts, and the clinical relevance of cerebellar lesions. Understanding cerebellar localization. So, this is essential for diagnosing patients with gait disturbance, incoordination, vertigo, and eye movement abnormalities. Three-dimensional pathway. So the cerebellum is located in the posterior cranial fossa, behind the pons and medulla, beneath the tentorium cerebelli, and it develops from the metencephalon. So cerebellum, it is located in the posterior cranial fossa, behind the pons and medulla, beneath the tentorium cerebelli, and it develops from the metencephalon. Structurally, it consists of two cerebellar hemispheres connected by the midline vermis. How is it connected? Here in this picture, you can see the two cerebellar hemispheres which is connected by the midline vermis. So the major surface landmarks include the anterior lobe, posterior lobe, and flocculonodular lobe. So what are the major surface landmarks? So these are the anterior lobe, posterior lobe, and flocculonodular lobe. So these are separated by the primary fissure and the posterolateral fissure. So how are these separated? These are separated by the primary fissure and the posterolateral fissure. The flocculus lies laterally and the cerebellar tonsils lie inferiorly. Flocculus lies laterally and cerebellar tonsils lie inferiorly. So the cerebellum communicates with the brainstem through the superior, middle, and inferior cerebellar peduncles. The cerebellum communicates with the brainstem through the superior, middle, and inferior cerebellar peduncles. Functional divisions. So vestibulocerebellum. Functional divisions of the cerebellum. So we have this vestibulocerebellum, flocculonodular lobe. So this flocculonodular lobe, it controls balance, vestibulo-ocular reflex, and eye movements through vestibular nuclei and the fastigial nucleus. So the lesions cause truncal ataxia, nystagmus, and vertigo. So if we take vestibulocerebellum, flocculonodular lobe. So this controls balance, vestibulo-ocular reflex, and eye movements through vestibular nuclei and fastigial nuclei. So these lesions cause truncal ataxia, nystagmus, and vertigo. Spinocerebellum, vermis and paravermis. So vestibulocerebellum is also called as archicerebellum. Spinocerebellum, it is also called as paleocerebellum, and cerebrocerebellum is also called as neocerebellum. So this spinocerebellum, vermis and paravermis, so this receives spinal proprioceptive input and regulates posture, gait, and muscle tone through the fastigial and interposed nuclei. Spinocerebellum receives spinal proprioceptive input and regulates posture, gait, and muscle tone through the fastigial and interposed nuclei. So lesions produce gait instability and truncal ataxia. So these lesions, it produce gait instability and truncal ataxia. Cerebrocerebellum, lateral hemisphere. So this communicates with the cerebral cortex via pontine nuclei and thalamus through the dentate nucleus. So this plans and times skilled voluntary movement. So lesions produce ipsilateral limb ataxia, dysmetria, and intention tremor. Cerebrocerebellum, lateral hemisphere. So this communicates with the cerebral cortex via pontine nuclei and thalamus through the dentate nucleus. So it plans and times skilled voluntary movement. Lesions produce ipsilateral limb ataxia, dysmetria, and intention tremor. So then deep cerebellar nuclei. So from medial to lateral, we have this deep cerebellar nuclei. So these are the, you can see the fastigial nucleus, globose, emboliform, and dentate nucleus. Deep cerebellar nuclei or fastigial, globose, emboliform, and dentate nucleus. Purkinje cells provide inhibitory GABAergic output to these nuclei. So what does these Purkinje cells do? They provide inhibitory GABAergic output to these nuclei. Then we have the cerebellar peduncles. So in the cerebellar peduncles, so what are the contents in the cerebellar peduncle? First we have inferior cerebellar peduncle. So it is mainly afferent. Inferior cerebellar peduncle is afferent. So this carries dorsal spinocerebellar, cuneo-cerebellar, vestibulocerebellar, olivocerebellar and reticulocerebellar fibers with efferents to vestibular nuclei. So mainly afferent. Then we have the efferent. So what are the afferents? So they carry dorsal spinocerebellar, cuneo-cerebellar, vestibulocerebellar, olivocerebellar and reticulocerebellar fibers with efferents to vestibular nuclei. Middle cerebellar peduncle, it entirely afferent, carries pontocerebellar fibers. Middle cerebellar peduncle, it is entirely afferent, it carries pontocerebellar fibers. Superior cerebellar peduncle, mainly efferent, carries dentatorubbrothalamic and cerebellothalamic pathways with ventral spinocerebellar afferents. So if you go to superior cerebellar peduncle, it is mainly efferent. Okay, so it carries dentatorubbrothalamic tract and cerebellothalamic pathways with ventral spinocerebellar afferents. Then coming to major afferent pathways. So the cerebellum receives, not afferent, okay. Corticopontocerebellar, what are the afferent pathways? From cortex, pons to cerebellum. Dorsal and ventral spinocerebellar, from spine to cerebellum. Cortex and pons to cerebellum. Dorsal and ventral spine to cerebellum. Cuneo-cerebellar, vestibulocerebellar, reticulocerebellar and olivocerebellar. So CRO, cuneo, vestibulo, reticulo and olivocerebellar. So most terminate as mossy fibers. Olivocerebellar fibers terminate as climbing fibers. So most of these fibers terminate as mossy fibers, but olivocerebellar fibers, they terminate as climbing fibers. Cerebellar cortex. The cortex has molecular, Purkinje and granular layers. So what are the layers of the cerebellum? So the cortex has molecular, Purkinje and granular layers. Molecular, Purkinje, granular layer. Molecular, Purkinje, granular layer. Okay. So mossy fibers synapse on the granule cells whose parallel fibers activate Purkinje cells. Mossy fibers, they synapse on the granule cells. Whose parallel fibers, they activate the Purkinje cells. So climbing fibers from the inferior olive directly activate the Purkinje cells, but the climbing fibers from the inferior olive, so this directly activates the Purkinje cells. Purkinje cells are the only output neurons of the cerebellar cortex. What are the output neurons of the cerebellar cortex? So these are nothing but Purkinje cells. So afferent pathways, cerebellar cortex and efferent pathways. So what are the efferent pathways? So dentate projects to the red nucleus and thalamus, interposed nuclei project to the red nucleus and fastigial nucleus projects to the vestibular nuclei and reticular formation. Dentate projects to the red nucleus and thalamus, interposed nuclei project to the red nucleus and fastigial nucleus projects to the vestibular nuclei and reticular formation. So blood supply. Posterior inferior cerebellar artery supplies the inferior cerebellum and is associated with the Wallenberg syndrome. Posterior inferior cerebellar artery. So this supplies the inferior cerebellum and is associated with the Wallenberg syndrome. Anterior inferior cerebellar artery, it supplies the anterior inferior cerebellum and may produce hearing loss when infarcted. Okay, and hearing loss with anterior inferior cerebellum. Then we have the superior cerebellar artery supplies the superior cerebellum and infarction causes limb ataxia and dysarthria. Okay, superior cerebellar artery, it supplies the superior cerebellum and infarction causes limb ataxia and dysarthria. Clinical localization. So how do you localize? So vestibulocerebellar lesions cause vertigo, nystagmus, gait ataxia. Vestibulocerebellar lesions, vertigo, nystagmus, gait ataxia. Spinocerebellar lesions cause truncal ataxia and postural instability. Truncal ataxia is caused by spinocerebellar lesions and postural instability. Cerebrocerebellar lesions cause dysmetria, dysdiadochokinesia and intention tremor. Cerebrocerebellar lesions, no, they cause dysmetria, dysdiadochokinesia and intention tremor. Cerebellar signs are usually ipsilateral. Cerebellar signs are usually ipsilateral. So what are the classical cerebellar signs? So the classical cerebellar signs are dysmetria. Then we have past pointing, intention tremor, was near the target, dysdiadochokinesia, that is impaired rapid alternating movements. Then we have the rebound phenomenon, that is a hypermetric response, hypotonia, pendular knee jerk, decreased damping. Then we have ocular dysmetria, nystagmus, scanning dysarthria and truncal or gait ataxia. So what are the classical cerebellar clinical signs? Dysmetria, intention tremor, dysdiadochokinesia, rebound phenomenon, hypotonia, pendular knee jerk, ocular dysmetria, nystagmus and truncal ataxia. So the cerebellum does not initiate movement, it coordinates, fine-tunes and times voluntary movement, maintains posture and equilibrium and supports motor learning. So it is not initiating the movement, it is coordinating, fine-tuning and timing the voluntary movement, maintains posture and equilibrium and supports the motor learning. So understanding its anatomy and pathway, so this is essential for accurate neurological localization. So inferior cerebellar peduncle, mainly afferent fibers, middle mainly entirely afferent, superior cerebellar, it is efferent fibers. So what are the different nuclei from medial to lateral? Fastigial, globose, dentate, FGED, fed, or you can remember as a FGED. Okay, so vestibulocerebellum, spinocerebellum, cerebrocerebellum. Okay, so vestibulocerebellum, vertigo, nystagmus, gait ataxia. Spinocerebellum, truncal ataxia, broad-based gait and rebound phenomenon. Cerebrocerebellum, dysmetria, intention tremor and dysdiadochokinesia. Deep nuclear lesions, same side limb ataxia. These are the ipsilateral signs. So deep nuclear lesions are more severe than the cortical lesions. So this is about the cerebellum.